For decades, we've been conditioned to believe that more medical testing equals better healthcare, especially as we age. The healthcare industry has convinced us that turning 65 means opening the floodgates to endless blood work, annual screenings, and preventive tests. But what if I told you that some of these routine blood tests your doctor orders after 65 might be doing more harm than good? Today, I want to share with you 7 blood tests that you might not actually need once you reach this milestone age, and why questioning them could be one of the smartest health decisions you make. I'm Dr. Evelyn Hart, and I've spent over 2 decades in clinical practice watching how our approach to senior healthcare has shifted from thoughtful, individualized care to a one-size-fits-all testing protocol that often ignores the unique needs and realities of mature adults. The medical establishment operates under the assumption that early detection always leads to better outcomes. But emerging research tells a different story, particularly for those over 65. The uncomfortable truth is that many blood tests routinely ordered for seniors can lead to false positives, unnecessary anxiety, overdiagnosis, and treatments that may reduce quality of life without extending it meaningfully. As we age, our bodies naturally change, and what might be considered abnormal in a 40-year-old could be perfectly normal variation in someone who's lived 7 decades of life. The first blood test that deserves serious questioning after 65 is the routine complete blood count with differential, particularly when ordered annually for asymptomatic individuals. Your doctor likely orders this test every year during your physical, checking your white blood cells, red blood cells, platelets, and hemoglobin levels. While this seems logical, research shows that in healthy adults over 65 without symptoms, annual CBC testing rarely leads to meaningful interventions that improve health outcomes. The problem lies in what we call age-related hematologic changes. As we mature, our bone marrow naturally becomes less efficient at producing blood cells. Hemoglobin levels typically decline slightly, white blood cell counts may decrease, and platelet function can change. These variations are often normal aging processes, not pathological conditions requiring treatment. When doctors see these changes on routine testing, they frequently order additional expensive tests, refer to specialists, or recommend treatments for conditions that don't actually need intervention. Consider what happens when your hemoglobin comes back slightly low. Instead of recognizing this as a possible normal aging change, many physicians immediately begin investigating for hidden bleeding, iron deficiency, or more serious conditions. This cascade of testing can include colonoscopies, upper endoscopies, iron studies, vitamin B12 levels, folate levels, and even bone marrow biopsies. Each test carries its own risks, costs, and potential for finding incidental abnormalities that lead to even more testing. The second problematic test is routine thyroid function screening in asymptomatic seniors. The American Thyroid Association and other professional organizations have moved away from recommending universal thyroid screening in older adults, yet many doctors continue ordering TSH levels annually for patients over 65 without any symptoms of thyroid dysfunction. Thyroid hormone levels naturally change with aging. The pituitary gland may become less sensitive to thyroid hormone feedback, leading to slight elevations in TSH that don't necessarily indicate true hypothyroidism. Additionally, many medications commonly prescribed to seniors can affect thyroid function tests without indicating actual thyroid disease. Drugs like amiodarone, lithium, steroids, and even some contrast agents used in imaging studies can cause temporary thyroid function abnormalities. When thyroid tests come back slightly abnormal in an asymptomatic senior, the standard response is often to prescribe thyroid replacement therapy. However, treating mild thyroid dysfunction in older adults, particularly those with TSH levels between 4 and 10, rarely improves symptoms or outcomes. In fact, thyroid hormone replacement in seniors can increase the risk of atrial fibrillation, bone loss, and cardiovascular complications, especially if the dose is too high. The research is particularly compelling here. Multiple large studies have shown that seniors with mildly elevated TSH levels who feel well and have no symptoms often do just as well without treatment as those who receive thyroid hormone replacement. The key is distinguishing between laboratory abnormalities and clinical disease. Our third concerning test is routine vitamin D screening in asymptomatic individuals over 65. Vitamin D testing has become incredibly popular, with laboratories reporting massive increases in test volume over the past decade. Many doctors now automatically include vitamin D levels in annual blood work, despite questionable evidence that this practice improves patient outcomes. The problem with vitamin D screening lies in both the interpretation of results and the subsequent interventions. Vitamin D levels fluctuate based on season, sun exposure, diet, and individual metabolism. What's considered optimal varies significantly between different medical organizations, with some suggesting levels above 30 nanograms per milliliter, while others recommend 40 or even 50 nanograms per milliliter. When vitamin D levels come back low, doctors typically prescribe high-dose vitamin D supplements, often in doses of 50,000 international units weekly. While vitamin D toxicity is rare, excessive supplementation can lead to hypercalcemia, kidney stones, and interference with other medications. More importantly, recent large randomized controlled trials have failed to show that vitamin D supplementation in community-dwelling seniors reduces fractures, falls, or cardiovascular events when compared to placebo. The fourth test that merits scrutiny is comprehensive metabolic panels ordered routinely in healthy seniors. This panel typically includes electrolytes, kidney function markers, liver enzymes, and glucose levels. While these tests can be valuable when there are specific symptoms or concerns, ordering them annually in asymptomatic older adults often leads to unnecessary follow-up testing and intervention. Kidney function naturally declines with age. After age 40, we typically lose about 1% of kidney function per year. This means that by age 70, it's completely normal for kidney function to be 20 to 30% lower than it was in young adulthood. When doctors see elevated creatinine levels or reduced estimated glomerular filtration rates in seniors, they often become concerned about kidney disease and initiate extensive workups including urinalysis, kidney ultrasounds, and nephrology consultations. Similarly, liver enzymes can be mildly elevated in seniors due to medications, supplements, or benign age-related changes in liver metabolism. A slightly elevated ALT or AST in an asymptomatic 70-year-old rarely indicates serious liver disease, yet it often triggers additional testing, including hepatitis panels, autoimmune markers, imaging studies, and sometimes even liver biopsies. The glucose component of metabolic panels presents its own challenges. Diabetes diagnosis criteria were developed primarily from studies in younger populations. As we age, insulin sensitivity naturally decreases and glucose tolerance changes. A fasting glucose of 110, or a hemoglobin. A1C of 6.2 in a 75-year-old may not carry the same implications as it would in a 50-year-old, yet our diagnostic criteria remain the same across all age groups. Our fifth questionable test is inflammatory marker screening, particularly C-reactive protein and erythrocyte sedimentation rate in asymptomatic seniors. These tests measure general inflammation in the body and have become popular as supposed predictors of cardiovascular risk and overall health status. The challenge with inflammatory markers in older adults is that low-grade inflammation is a normal part of aging, a phenomenon scientists call inflammaging. As our immune systems mature, they maintain a slightly higher baseline level of inflammatory activity. This means that mildly elevated CRP or ESR levels in a healthy 70-year-old might be completely normal rather than indicative of disease. When these tests come back elevated, doctors often embark on extensive searches for hidden infections, autoimmune diseases, or malignancies. Patients undergo CT scans, bone marrow biopsies, rheumatology consultations, and numerous other inflammatory marker tests. The vast majority of these workups find nothing clinically significant, yet they subject seniors to unnecessary radiation exposure, procedural risks, and psychological stress. Moreover, there's limited evidence that treating mildly elevated inflammatory markers in asymptomatic seniors improves outcomes. Anti-inflammatory medications like steroids or NSAIDs carry significant risks in older adults, including increased infection susceptibility, bone loss, cardiovascular complications, and gastrointestinal bleeding. The sixth test category that deserves questioning is extensive lipid panels and advanced cardiac risk markers in very senior adults, particularly those over 75. While cholesterol management has clear benefits in younger populations and those with established cardiovascular disease, the evidence becomes much less compelling in very elderly individuals without existing heart disease. Standard lipid panels measure total cholesterol, LDL cholesterol, HDL cholesterol, and triglycerides. Advanced panels might include particle size analysis, apolipoprotein levels, and other specialized markers. The problem is that cholesterol metabolism changes significantly with aging, and the relationship between cholesterol levels and cardiovascular outcomes becomes weaker in very elderly populations. Multiple studies have shown that in adults over 75 without established cardiovascular disease, LDL cholesterol levels have little to no correlation with future heart attacks or strokes. Some research even suggests that slightly higher cholesterol levels might be protective in very elderly individuals, possibly due to cholesterol's role in immune function and cellular repair. When lipid panels come back elevated in elderly patients, doctors frequently prescribe statins or other cholesterol-lowering medications. While these drugs have clear benefits in younger populations and those with existing heart disease, their use in very elderly primary prevention patients is controversial. Statins can cause muscle pain, cognitive side effects, and drug interactions that may outweigh their benefits in patients with limited life expectancy. The seventh and final test that warrants careful consideration is tumor marker screening in asymptomatic seniors. Tests like PSA for prostate cancer, CA12-5 for ovarian cancer, CEA for colon cancer, and others are sometimes included in routine blood work for older adults, despite limited evidence supporting their use as screening tools in asymptomatic individuals. The fundamental problem with tumor markers is their lack of specificity and sensitivity. Many conditions besides cancer can elevate these markers, including infections, inflammation, benign tumors, and normal aging processes. When tumor markers come back elevated, patients often undergo extensive and invasive testing, including biopsies, imaging studies, and surgical procedures. PSA testing exemplifies these issues perfectly. While PSA can be elevated in prostate cancer, it's also commonly elevated due to benign prostatic hyperplasia, prostatitis, recent sexual activity, bicycle riding, and many other non-cancerous causes. The United States Preventive Services Task Force now recommends against routine PSA screening in men over 70 because the harms of overdiagnosis and overtreatment outweigh the potential benefits. Similarly, CA125 is elevated in numerous benign conditions, including endometriosis, fibroids, liver disease, and even normal menstruation. Using it as a screening tool in asymptomatic women leads to numerous false positives and unnecessary surgical interventions. Now, I want to be absolutely clear that I'm not suggesting you should refuse all blood tests or ignore your doctor's recommendations. What I'm advocating for is informed, shared decision-making between you and your healthcare provider. When your doctor orders blood tests, ask specific questions about why each test is necessary, what the results might change about your treatment, and what the potential downsides might be. Consider the story of Margaret, a 72-year-old patient I saw who had been getting extensive annual blood work for years. Her previous doctor ordered dozens of tests annually, including many of the ones I've discussed today. When Margaret's vitamin D came back slightly low, she was prescribed high-dose supplements that caused nausea and constipation. When her inflammatory markers were mildly elevated, she underwent a CT scan that found a small lung nodule, leading to months of anxiety and additional imaging before it was determined to be benign. After we discussed the limited benefits of many of these tests in asymptomatic individuals, Margaret chose to focus on fewer, more targeted tests based on her symptoms and risk factors. Her anxiety decreased, her quality of life improved, and her overall health outcomes remained excellent. The key is understanding that medicine is not black and white, particularly in geriatric care. What's appropriate for a 40-year-old may not be appropriate for an 80-year-old. Life expectancy, competing health risks, medication interactions, and personal values all need to be considered when making testing decisions. When evaluating whether you need a particular blood test after 65, consider asking your doctor these important questions. First, what specific symptoms or risk factors make this test necessary for me individually? Second, how will the results change my treatment plan or quality of life? Third, what are the potential risks or downsides of this test? Fourth, what happens if we don't do this test? And finally, is this test recommended by major medical organizations for someone my age with my health status? Remember that good medicine sometimes means doing less, not more. The goal of healthcare in your later years should be maintaining quality of life, managing symptoms that bother you, and preventing complications from conditions you actually have. It should not be an endless search for laboratory abnormalities that may or may not represent real disease. The most important tests for seniors are often the simplest ones. Basic metabolic panels when you're having symptoms, hemoglobin levels if you're feeling fatigued, and targeted testing based on your specific health concerns often provide much more value than extensive routine screening panels. As you navigate healthcare decisions after 65, remember that you are the most important member of your healthcare team. You have the right to understand why tests are being ordered, to ask questions about their necessity, and to make informed decisions about your care. Quality. Healthcare is not about the quantity of tests performed, but about the appropriateness and thoughtfulness of medical interventions. The path forward is not about avoiding all medical care, but about making sure that every test, every procedure, and every treatment serves your individual health goals and improves your quality of life. By questioning unnecessary testing, you're not being difficult or non-compliant. You're being a wise advocate for your own health and well-being. Your health is too important to leave entirely to protocol and routine. Take control by asking the right questions, understanding your options, and making decisions that align with your values and goals for your golden years.